Okay, online students, back to the health assessment checkoff sheet. I will now be going over Roman number 12 and 13, which is cardiovascular and peripheral vascular. And if you don't have your book, you'll need to get it out. We'll be going over mainly what's in chapter 19 and chapter 20 for this section so that you'll know what to expect on the day of checkoffs. Okay, I'm going to get off here. And if you see my duck, let me know. Can't find the thing again. All right. So let's get into our course here. Let's see here. Okay, shut your eyes for a minute. It'll be going rather rapidly. Alrighty. So we're going over Roman numeral 12 and Roman numeral 13. So in the cardiovascular system, it's going to be worth 15 points. And the first thing you're going to do is inspection. And it talks about you want to inspect. And what you're inspecting for when you look at the anterior chest, you're looking at for heaves, which is kind of a lift. And how you would do that is get down beside the patient with them laying on their back, and you would look across their back, and you would see if there is a sustained forceful thrusting of the ventricle during systole. It occurs if there's hypertrophy, like if there's increased heart workload on the heart. A right ventricular heave is seen usually at the sternal border, so that's where you would look. So it's kind of like an abnormal lift or pulsation that you would see at that area. Okay, so you would look for heaves. Then you would palpate, and you would palpate for the apical pulse, and it shows you how to do that on page 473. You would palpate, this used to be called the point of maximum impulse, or PMI, and because some abnormal conditions may cause a maximal impulse to be felt elsewhere on the chest, now they use the term apical impulse, which is specifically for the apex beat. So it shows you where you're going to do that. You would localize the apex impulse precisely by using one finger pad and asking the person to exhale and hold it. That aids the examiner in locating the pulsation, usually about the fifth intercostal space. You will need to roll the person midway to the left to find it, and because that displaces the apical impulse even further to the left. So you have them turn over a little bit to their left, and once you find it, you would note the location, the amplitude, and the duration. Okay, the apical impulse is palpable in about half of adults. It is not palpable in very obese people and people with very thick chest walls. You can forget it. You probably will not be able to palpate the apical impulse. All right, then you're going to check for thrills. A thrill, this is on page 474, is a palpable vibration. Okay, it's felt on the chest wall, and it feels like the throat of a purring cat, if you've ever felt of that. The thrill signifies turbulent blood flow and accounts for loud murmurs. So you would feel across the chest, and you would be feeling if you could palpate what's called a thrill, or you would be palpating for vibrations. Then you would do palpation again at all points. This time you're going to be palpating at what's called the aortic, the pulmonic, the herbs, the tricuspid, the mitral, and the apex. Okay. And especially the aortic, pulmonic, herbs, tricuspid, and mitral. So the way that I remember that is all people enjoy Tootsie Roll midgets. Okay. So it shows you a picture of where you're going to listen to those on page 475. And they have revised that just a little bit. You can see there the old method of reviewing it versus the new method. You can see that you're going to be listening at the aortic is where you're going to palpate first, and you're going to do that at your second right intercostal space. So you would palpate there, see if you feel any thrills, vibrations, pulsations. Then you would go straight across to your pulmonic at about your second intercostal space on the left. Then go down on the third intercostal space on the left, and that's herbs. Then you would go down to the fifth intercostal space, and that's your tricuspid, mid-sternal border. And then midclavicular line is where your mitral is at the fifth intercostal space. So you would palpate each one of those spaces. Then you would auscultate each one of those spaces, okay, and see what you hear. And of course, you could also do the apex of the heart. So that is the kind of pattern that you're going to be listening for. Then you're going to do comparing of the apical and the radial pulses, and it talks about that on page 476. You're going to note if there is a pulse deficit, if there's any irregularity, whenever you are doing the apical and the radial. The two counts should be identical. If they're different, then you subtract the radial pulse from the apical pulse and record the remainder as a pulse deficit. So if you got like 70 apical, and then you got, for the radial pulse, 80, you would subtract that, and that would be a pulse deficit of 10, okay? But they should be, in a normal person, those should be the same. If they're different, a pulse deficit usually signals a weak contraction of the ventricles, and it occurs when atrial fibrillation, or they're having some type of premature beats like PVCs or PACs. And also someone who's have CHF or in heart failure may also have a pulse deficit. So that would be, you would hear pulse deficit. And again, that if you have a pulse deficit, that's a weak contraction of the ventricles. So you can see there as she is comparing them, you would compare the apical pulse with the radial pulse. And in this picture, she's actually also comparing the carotid pulse with the apical pulse, but you will be doing the radial. All right, as far as the peripheral vascular system, it's worth 12 points, and that's in chapter 20. So we'll go over a chapter. With this one, first you're going to do palpation, and you'll do palpation of all of your pulses. So you're going to be doing the femoral, the ulnar, the radial, the dorsal pedis, the brachial, the posterior tibial, the carotid, the popliteal, and you won't have to do the jugular and grade them. So leave the jugular off. You'll be doing the femoral through the popliteal. Now, again, when you do that, if you look on page 507, while you're at the hands, you always want to check for cap refill. Then you want to do both pulses at the same time because you're seeing if they are equal. You're also would be doing them on a point scale, with +2 being normal. If they're weak, then it's a +1. If they're absent, a 0. Or if they're bounding, it would be a 3+. Okay. What does that indicate? If it's a full bounding pulse, that's when you have things they may have just gotten through exercising, may have some anxiety, fever. You also see that in hyperthyroidism. Remember, everything speeds up with hyperthyroidism, anemia. If it's a weak, thready pulse, a 1+, that occurs with people who have shock or peripheral artery disease. So that would be what you would expect to find with them. So 2+ is normal. Okay. Now, it usually is not necessary to palpate the ulnar pulses, but we're going to. But know that they are harder to feel and harder to palpate in the normal person. So it's normal to get 1+ on those a lot. On page 508, it shows you where to feel the brachial pulses. Their forces should be equal bilaterally. So make sure you're feeling those in the right area on the inner aspect towards the elbow. While you're here, you can also check the epitrochlear lymph nodes if you want to, and it shows you how to do those. Then you would check the femoral and popliteal, and it shows you how to do those on page 511. Feeling the femoral artery, and then the popliteal. Again, the popliteal is a little bit harder to feel. You anchor your thumbs on the knee and curve your fingers around the popliteal fossa. Press your fingers towards forward hard to compress the artery against the bone. And again, a lot of times this one is hard to feel. Having them bend their knee slightly sometimes will help, or having them turn on their back so you can feel it. The posterior tibs on 512, it shows you where to feel for the posterior tibial. You can note that they're on the inner aspect of the ankle, not the outer aspect, so make sure that you're feeling in the correct spot. And then the dorsalis pedis is on page 513, where you would feel of that. While you're at the feet, you also check for edema to make sure that there's no swelling. Okay, so that's checking all the pulses and grading them. So make sure you grade them as you go. And you're doing them on both sides at the same time. Then you're going to auscultate for bruits at the carotid, the abdominal, and the femoral arteries. And then you're going to inspect the carotid and jugular vein. So then you would go back and inspect the carotid and inspect the jugular vein as well. All right, so you'd feel the carotid. When you do that, you check for the pulse. You do not do that at the same time. You do them one at a time. The jugular vein, you probably will not be able to feel, but inspecting the jugular vein pulse is on page 472. It says from the jugular veins, you will assess what's called central venous pressure and thus judge the heart's efficiency as a pump. Stand on the person's right side because the veins that are there have a direct route to the heart. The internal jugular vein pulsates for the CPV assessment. You can see the top of the external jugular vein distension overlying the sternomastoid muscle. Position the person supine about 30-degree angle, and then look for the veins for pulsation. The higher the venous pressure is, the higher the position that you're going to need to see that pulsation. Okay, as the person's raised to a sitting position, the jugular should flatten and actually disappear at about an angle of 45. Okay, so you could actually measure that and see where the jugular vein actually goes back down, and that should be at about a 45-degree angle. Okay. So that's it on the cardiovascular system and the peripheral vascular system. If you have any questions about either one of those, please contact me and I'll be happy to go over that again. Thanks.